Good morning, everyone. I thank you, Dr. Liu and Dr. Shen, for inviting me to this talk. So I'm Harrison Bai. I'm assistant professor of diagnostic imaging from Brown University. I'm a radiologist. So today I'm going to talk about AI augmentation of radiologist performance in distinguishing COVID-19 from other pneumonia on chest CT. So the objectives of my talk today is to demonstrate an example of how AI based on medical imaging can be used for diagnosis of COVID-19. I want to discuss the challenges, the limitations, and some future directions of our research. Also, I want to exchange ideas, elicit some feedback, and importantly, I want to seek collaboration with people from other institutions and universities around the world. So in terms of study design, we basically designed the study to distinguish COVID-19 pneumonia from pneumonia of other etiologies. So we searched the institutional, the montage, use a montage search to identify patients with other pneumonia from 2 hospitals in the United States and also 1 hospital in China for our other pneumonia cohort. We excluded those patients with no chest CT scans. And then we manually reviewed the radiology reports and the images for part of our cohort to make sure that the imaging findings are consistent with pneumonia, and also for a portion of our cohort, we also have microbiology correlation from the respiratory pathogen test. And we ended up with 665 chest CT scans with findings suggestive of pneumonia. For our COVID-19 cohort, we identified by positive RT-PCR and also available CT from 1 hospital in the United States and 9 hospitals in Hunan province in China. We excluded patients with normal chest CT, and we identified a final cohort of 521 patients. So the total number of CT scans used for our AI study is 1,186. So this is our research design for the AI algorithm. So we first did automated long segmentations, and then after that we trained the deep neural network to identify those slices that contain pathology, with the gold standard being labeling by radiologists. And then we divided our final cohort into a training set, validation set, and test set in a standard ratio of 7:2:1 to build our COVID-19 classification neural network. We perform external testing by leave out data from 3 institutions, and then we also did what is called equal split, which is an equal splitting of the training and validation test set. And then we have 6 radiologists to evaluate our test set, and then we compare the performance between the AI and the radiologists. And finally, we wanted to see how the AI algorithm can help the radiologists in this specific task. So we asked the radiologists to evaluate the scans again with the probabilities provided by the AI algorithm. So this is the deep learning architecture we use. So we use what is called an efficient net, and basically we get slice level prediction from each patient, and then we use a 2-layer neural network to pull the predictions from each slice to get our patient level prediction. So for the data, we have 3 so for our training validation test set split, which I mentioned earlier, for the internal testing, we split it into in the 7:2:1 ratio, and external testing was done by leaving out three institutions, data from three institutions, and then finally we split the training validation test set into approximately equal sample size. So patient demographics, we compare the baseline characteristics between the COVID-19 and our non-COVID-19 pneumonia cohort, and there were definitely differences between these two. As you can see here, the mean age, the non-COVID-19 pneumonia patients are much older and also tend to have more comorbidities than the COVID-19 pneumonia cohort. We also look at the days of infection, look at the time between symptom onset and the chest CT, because as we all know, the appearance can be very different depending on when the chest CT was performed. And we can see here that there's a wide distribution on when the chest CT was done, and we basically took the first chest CT we could find for each patient, and for our AI performance, we achieved pretty good results for the internal testing, and then when we did external testing, we did see a slight like a decrease in performance from an accuracy of 96% to 87% on the external testing set. And then, so we wanted to figure out whether is this due to the fact that, there's some difficulty in generalization, or is it because the way we split the data set, in like a 7:2:1 ratio. So we instead try to split our data set in approximately equally among the training and validation test, and we see that the performance is, for the equal split is somewhere in between the internal testing and external testing. So we think that, probably both factors affected the drop in performance on external testing. Then we compare the radiologist's performance with the AI performance, and we basically for each radiologist, and of course there is a variation in radiologist performance. Some radiologists performs better than others, and we compared the average performance and found that our AI algorithm is to perform better than radiologists. And this is just a figure showing the ROC curve, comparing the AI algorithm with each of the radiology experts. So just to make sure that our AI algorithm is actually focusing on the disease area, so we did something called a gray cam, which is the visualization technique we chose, and basically we showed a couple of slices where representative slices where we showed that the AI algorithm is actually focusing on the disease area of the lung. And then we look at cases where most radiologists misclassified, and by most radiologists, we basically took 4 out of 6 as our number, and then so these are the 6 cases that we chose to display, and for the top 3 and the bottom, the first 2 on the bottom are the ones that the radiologists were wrong, but the AI algorithm was right. And for the last one on the bottom right, both the radiologists and the AI were wrong. And what we see here is basically some atypical findings that, for instance, for the ones that, for the COVID-19 that the radiologists got wrong is either, just a focal finding that can be mistaken for pneumonia, or it could be the one on the upper left where, it could be, looks like patchy edema or something. And similarly on the bottom, the non-COVID-19 that was misclassified as COVID-19. I mean, you can see that the appearance is not the typical that you would see for COVID-19. And lastly, we want to see if the AI can assist radiologists in performing this task. So we asked the radiologist, the same radiologist, to evaluate the scans again, given the probabilities from the AI algorithm. And so we calculated the difference in performance with AI assistance and without AI assistance. And we found that the AI algorithm was able to improve the radiologist's performance on average. And of course, there is a lot of variation in performance among the different radiologists. So some improved while others may not have improved. So there are a lot of challenges with our study. Basically, since we are getting scans from a lot of different hospitals in China and the United States, every place has different scanners, different scanning protocols, and that's a major challenge, is to how to minimize the effects of the different CT protocols. And also I mentioned about the differences in baseline characteristics between the COVID-19 and the non-COVID-19 pneumonia cohort, which could have introduced a bias in our algorithm, because the non-COVID-19 cohort is much older and also has more comorbidities, and likely that can be reflected on the CT scan as well. So we also look at some different parameters just to see how things are different. And one thing we look at is slide thickness. We found that for the internal testing, where we split into 7:2:1, the slide thickness is pretty much the same among training validation tests, and same for the equal split, where we split just into equal sample size. And but of course, if we do external testing, then of course, there's a difference in slide thickness due to the differences in among the institutions. So the way we try to solve this problem is basically use lung segmentation. We basically, because we don't want the algorithm to focus on anything else outside the lung, we also just normalize the CT to lung window, and those are the things we did. So there are many limitations of our study, and I'm just going to discuss a couple here. First of all, in general, the diagnostic role of CT in COVID-19 is not very certain, because especially in the United States, where it's definitely not considered the first line. And also our classifier only differentiates COVID-19 from other pneumonia. So one criticism could be that it doesn't really tell, there could be other pathologies that imitate COVID-19 as well, other than other pneumonia. So the application could be limited. So we don't have like I mentioned earlier, we have the gold standard for a portion of our other pneumonia cohort using the respiratory pathogen test to show the viral species, but we do not have that for all of our patients, especially those coming from China. So we have to rely, so we don't really know the specific breakdown between bacterial versus viral pneumonia for those patients. And lastly is the timing of the CT is very important because the most important role of AI is probably to distinguishing between the two at an early stage when it's most difficult, or maybe the sensitivity of the RT-PCR is not that high. So we wanted to do that as well, but it's the cohort size is very limited. So and there are a couple of technical limitations as well. One problem we found is the AI would learn the scan characteristics rather than the actual disease if we don't do something like the lung segmentation and normalizing our scans, and that's a major problem we try to solve. And also we use a 2D implementation, which supposedly could have been improved with 3D. Also, there are multiple steps in our pipeline, which including identifying the slice, lung segmentation, which supposedly we could have eliminated and are working on to eliminate. And finally, our algorithm is considered a black box algorithm. So it would be better if we can improve the to demonstrate better how the algorithm works. So future directions, we want, these are the things we want to work on and or are working on right now is disease segmentation, predict the prognosis of the patients using CT and clinical data. We want to increase our sample size because with AI, this type of study, it's really the sample size is very, very important. And lastly, the real-time implementation. We want to implement our algorithm and test it in real time so that it can be used to help clinicians. So I want to thank the following people and my team and collaborators from both my institution and other institutions in China and the United States.